Welcome and thank you for joining us for the Board of Certifications CARE Educational Series. My name is Shannon Fleming and I will be moderating today's session. Before we begin, I just have a few announcements. I'd like to take this opportunity to remind you of AT Regulatory Connect, the secure portal for state regulators. AT Regulatory Connect provides regulators access to certification verifications, the regulatory network, the disciplinary action exchange, and the many resources we have to offer. As you may have heard, the CARE Conference 2021 has been postponed to July 2022. CARE Conference 2022 will be held in Omaha, Nebraska, July 15th through the 16th at the Omaha Marriott Downtown Capital District. In lieu of an in-person conference this year, the BOC is hosting an educational series of articles and webinars. Please visit the BOC website to review previous topics and articles. This particular webinar is our final planned event for the series. Today's webinar is titled State Telehealth Policy Landscape Post-Pandemic. Please feel free to submit questions via the Q&A feature. We will answer as many questions as possible at the end of today's presentation. This webinar is being recorded. Before introducing today's presenter, we would like to share a brief video that is a collection of video clips from athletic trainers who have implemented telehealth as a result of the pandemic. Here are their stories.
My name is Jeff Zapanski, and I'm an associate manager with Ohio Health Sports Medicine based out of Dublin, Ohio. I'm also a member of the athletic training section of the Ohio Occupational Therapy, Physical Therapy, and Athletic Trainers Board. I think I have a little bit of a unique perspective when it comes to telehealth, both overseeing athletic trainers practicing clinically in the secondary and collegiate setting, as well as from the regulatory side. At Ohio Health, we had the tools in place prior to the pandemic to adopt telehealth. However, over the course of the pandemic, without a doubt, our staff certainly became more comfortable with those tools and we had a higher utilization of those resources. From a regulatory side, the awareness around telehealth certainly spiked, and I would say a majority of the questions revolved around reimbursement. I think for me, the long-staying aspect of telehealth that I'm interested to see how it plays out is the continued use of video visits. Throughout the pandemic, the end user training, comfortability, regulation, patient safety, documentation, and security certainly has become much more robust.
Hi everyone, my name is Amanda Donahue and I am the athletic trainer for the Palladino School of Dance and School of the Arts at Dean College located in Franklin, Massachusetts. Today I'm here to talk about how I pivoted during the COVID-19 pandemic and provided telehealth services and virtual care to our performers at Dean. Our dance technique and movement-based classes utilized the Zoom platform, while telehealth services were completed under the secure platform of Microsoft Teams. Telehealth was very new to me, as it is to many athletic trainers, but it forced me to grow as a clinician. It honed my verbal cueing and physical demonstration of exercises, pushed me to think creatively, and most importantly, allowed me to stay connected to my patients. My patients were empowered with telehealth because it gave them the opportunity to heal themselves through movement only without relying upon manual therapy from me, which during a time that was chaotic and ever-changing gave them an increased sense of control. Telehealth also allowed me to connect with my patients who tested positive for COVID and assist them with breathing strategies to help them with recovery. And to those who were recovering from eating disorders and suddenly found themselves moving less and concerned that they were going to put on weight, critical in their overall support. Outside of telehealth, I was given the opportunity to lead virtual movement warm-up and cross-training sessions with our performers. I also helped guide students in creating a safe place to dance in their homes, as well as developing an emergency action plan for our faculty and students to utilize in the virtual platform. And sure enough, that was put to use when one of our dancers passed out during a dance final at the end of the semester. Thankfully, our faculty knew what to do and the dancer was okay. During the summer, our college announced we would continue with virtual learning for the fall semester. In order to secure my job for the fall, I relied upon my statistics from the spring, a number of injuries sustained at home, amount of telehealth services provided, and developed a game plan on how patients from out of state would be handled. In discussion with legal, our overseeing physicians, and the athletic trainers in Massachusetts, this was all very much and still is a gray area. I also collaborated with our ballet faculty to create a new hybrid course entitled The Biomechanics of Point, where I developed and incorporated a virtual movement screen for our dancers. And finally, this past semester, where we transitioned to the hybrid platform, allowing for both in-person and continued telehealth care. Again, critical to be able to maintain a virtual video connection with my students in isolation or quarantine, recovering from COVID, who are faced with shortness of breath or congestion, and simply guiding them in breathing strategies in the prone position to help that in many cases a significant improvement in their comfort. Telehealth has made me a better clinician and has created more opportunities for me within the college. I encourage you to learn more about telehealth and continue to evolve our profession. Thank you.
Hi, my name is Scott Zema, and I'm a clinical assistant professor and athletics healthcare administrator at California University of Pennsylvania. I've been asked to provide my experiences during the pandemic, particularly with telehealth. I never utilized telehealth prior to March 13th, 2020, when California University of Pennsylvania was shut down for in-person classes, athletics, and contacts. Since we were still in the middle of spring operations, our student athletes were still in need of services. One way I was able to provide services were the use of Zoom telehealth. Any student athlete who needed to make an appointment was given my Zoom telehealth link, and they were put into a virtual waiting room. Once I was ready, I was able to invite them into the room, conference, and I was able to provide telehealth services for them. To be honest, this was very difficult at first, and definitely a learning curve on my part. However, once I was more comfortable with this medium, I felt that the services I was able to provide were beneficial to the student athlete. One aspect that I really liked was I was able to have one-on-one concentrated history gathering time with the student athlete, something that, to be quite honest, is a moving target with a full and dynamic athletic training facility. I felt that I was able to establish a good rapport with my student athletes who took advantage of the telehealth appointments, and I was able to get a good in-depth history from them. In fact, it was such a good experience for the student athletes and the feedback that I was getting from them, I continued the telehealth initial appointments in the spring semester when we were back at a more hybrid and in-person contact with them. So I was able to do their telehealth with them prior to bringing them into the facility for any hands-on portion of the evaluation. And this mitigated the contact time that I had with the student athlete and kept the flow in the athletic training facility to a reasonable level.
Hello from NASA's Kennedy Space Center in Florida. My name is Mary Kirkland and I manage the RehabWorks clinic here. And it's a very quiet clinic today due to the COVID-19 pandemic. March 18th of 2020 was a day that I will always remember in my 32-year career, where we had talked pandemic, but never in my lifetime thought that it would come to fruition. But here we are. And prior to COVID-19, we had not been doing telehealth services for the KC workforce. One huge advantage for us is we already had an in-house EMR in operation, so that enabled us a pretty seamless transition to telehealth services, along with MS Teams, the MedBridge web-based portal, and the relaxation of HIPAA regulations for us here in Florida and for you across the country. Telehealth is different, absolutely, from the inpatient services that we have done since 1997 here with RehabWorks. It's not ideal, but it does enable us to maintain contact with the employees, provide advice, and do virtual assessments and provide them with home programs and instructions and or referrals to outside providers, which is very much appreciated because they can maintain that continuity with us. And telehealth, telemedicine is not going to go away. I project that probably 40% of our workforce will remain telework because they can. They found that it's very productive for them and they enjoy it more. So for us and for all of you across the country and our athletic training profession, telehealth is here to stay, and I very much thank the BOC and appreciate their efforts to keep us informed and up to date on regulation related to telehealth and how it will affect us now and far into the future. Take care, my friends and colleagues. Be well and stay safe.
Thank you to Jeff, Amanda, Scott, and Mary for sharing their stories. Okay, so today our presenter is Jack Pitzer. Jack is a research analyst in the health program at the National Conference of State Legislators. He provides research and technical assistance on access, costs, and coverage policy, including private health insurance oversight, rural access to care, telehealth, health facility regulation, cost containment strategies, and state responses to COVID-19. He has written several publications and tracks legislation across all 50 states relating to these topics. Prior to NCSL, Jack worked as an education program coordinator at a youth detention center in Belize City, Belize, through the Jesuit Volunteer Corps. He received his BS in Health Administration and Policy from Creighton University right here in Omaha, Nebraska. All right, well, thank you, Jack. I'll hand it over to you.
Yes, thank you, Shannon, and thank you everyone for having me here today to discuss the state telehealth policy landscape post-COVID. I really appreciated watching that video on how you all are incorporating telehealth into your practice. I found it incredibly insightful and really interested in the ways that you all are considering how to continue using telehealth once the COVID-19 pandemic eventually, hopefully very soon, officially goes away. And yes, I did want to mention I am a proud Creighton alum, which is located in Omaha, Nebraska, where the BOC is also headquartered and where you all will be having your in-person conference next year. So deep love for that city and roll Jays. But to briefly reintroduce myself, my name is Jack Pitzer. I am a research analyst with NCSL's health program focusing on access, cost, and coverage policy. And as Shannon said, that includes private insurance, rural health care, telehealth, cost containment strategies, and a host of other policy areas. But on the next slide, you will see that clearly we are here today to discuss telehealth. So for today's agenda, I'm first going to do just a little bit of level setting over what is telehealth, especially in the context within the states and state legislation. Then I will briefly touch on some federal actions related to telehealth and COVID-19. I'm going to go more in depth over state actions and state legislative trends related to telehealth. And then I want to wrap up with just a little bit of a 101 on how to best engage state legislators on policy priorities for you all as athletic trainers. So on the next slide, before we get started, I wanted to provide some background on the National Conference of State Legislatures, just for some context. So NCSL is the national bipartisan membership organization, which exclusively serves the 7,383 state legislators, as well as nearly 30,000 legislative staffers. And this is across all 50 states, DC, the Commonwealths, and Puerto Rico. And on the next slide, our mission is to advance the effectiveness, independence, and integrity of state legislatures, foster interstate cooperation, and facilitate the exchange of information between states. And we do this through several services to our members, which I have listed here on this slide. We also support states on the federal level, especially in support of state flexibility and to prevent unwarranted federal preemption to the states. But I did want to point out that NCSL does not endorse any specific type of state legislation or state policy action, but rather we are here merely to provide nonpartisan information, legislative trends, and state examples. So all of the things I'll be discussing today on telehealth are merely for informational purposes and does not indicate NCSL's endorsement. So next slide. With that super fun background out of the way, let's get down to business. And I'd love to have people participate in a little activity to get us started. So if you want to enter into the chat, what is one change you hope to continue for the long haul after COVID-19? So that could be donning your mask when you go to the grocery store during flu season, doing more outdoor activities. My boss said she wants to continue wearing sweatpants while working, which is very relatable. So it could be anything really. And while you all are entering that into the chat, I can go ahead and share what I want to keep doing post-COVID. And that's I've been doing a lot of virtual cooking sessions with my friends that are scattered across the United States. And those virtual cooking sessions have, one, been very helpful for my cooking skills, which needed a lot of work, but also has been a really fun way to connect with my friends. So that is one thing that I hope to continue doing post-COVID. And now checking the chat, it looks like you all kind of have a few COVID-induced changes that you'd like to keep, including cooking skills, so I can relate, keeping a hybrid work schedule, more outdoor activities, all really, really great ideas. So on the next slide, we are not the only ones that are having these conversations over which COVID-induced changes we want to keep permanently. As you all are very much aware of, there has been an explosion of telehealth use during the COVID-19 pandemic, along with a lot of policy changes in order to increase access to telehealth. And now federal and state policymakers are looking at these changes, and they are trying to decide which ones they want to keep permanently. But before I get into those federal and state actions, I thought it would be helpful just to do a little bit of background on what telehealth is and the different type of telehealth modalities that we discuss most frequently with the states and with state legislators. So telehealth uses technology to provide healthcare and other health-related services remotely. And this includes communication and education between patients and providers, as well as certain opportunities between providers themselves. And we often discuss telehealth within the context of healthcare workforce shortages. And although telehealth does not increase the number of healthcare workers, it does help increase the efficiency and the reach of the existing health workforce. And another important thing to note is that telehealth itself is not a service, but rather a means of delivering healthcare services, which is vital in order to increase access to care, especially during the COVID-19 pandemic, to ensure continuity of care, which some people had mentioned in that athletic trainers video at the beginning of this. And when we talk about telehealth with the states and with state legislators and in relation to state law, we're typically referring to three primary telehealth modalities. And these are real-time communication, which allow patients to connect in real time with providers, often through video conferencing. Then there's store and forward telehealth, which refers to the transmission of data, images, sound, or video from one care site to another for a provider then at that other care site to evaluate that information. And then there's remote patient monitoring, which involves collecting a patient's vital signs or other health data while the patient is at home or some other care site. And then a remote provider then looks at that healthcare data for monitoring and response purposes as needed. Next slide. Okay, so as I have said before, both federal and state policymakers have pursued several policy actions in order to increase access to care during the pandemic. And at the federal level, a lot of these changes relate to Medicare. So some changes to Medicare include removing geographic restrictions on where a patient can be located when receiving services through telehealth, as well as allowing patients to receive services in the comfort of their own home. And Medicare also allowed providers themselves to deliver healthcare services at their own home under certain circumstances. Medicare also expanded the types of acceptable telehealth modalities, including telephone consultations, which previously were pretty restricted and not common. And then Medicare also allowed all health professionals to bill Medicare for their professional services and added nearly 240 additional codes for reimbursement for services that were delivered through telehealth. And then Medicare also tied reimbursement for telehealth to what they would pay for in-person care. Many of these changes are temporary during the declared public health emergency. There is pending federal legislation, the Connect for Health Act, which would make permanent many of these changes, such as lifting those geographic restrictions and allowing patients to receive services in their home. But for full transparency as well, I want to caveat that I have a closer eye to the states, but I do have my DC colleague and colleague in DC, Haley Nicholson, who really tracks some more of those federal actions more closely. And so if you do have any questions related to that Medicare side of things, I'm happy to pass along questions to her. Next slide. Okay, so with the federal part covered, I'm going to take some time to go into detail over state actions, both actions specific to COVID-19, as well as general legislative trends related to coverage and provider licensing requirements. However, I did want to note that some of these actions may not directly affect athletic trainers or directly reference athletic trainers, but may affect other types of providers such as physicians, nurse practitioners, physician assistants, and others. But I have tried to pull examples that do specifically reference athletic trainers when I could. And I also think generally these state trends will hopefully give you all a good understanding of where we're currently at with the state telehealth policy landscape. So all 50 states, DC, and Puerto Rico implemented some sort of policy change to increase access to telehealth during the COVID-19 pandemic. And this could happen through legislation or through governor's offices, Medicaid agencies, licensing boards, or other state agencies. A number of these actions were temporary and tied to governor's emergency declarations. But that being said, as of today, there have been at least 25 states that have enacted over 34 bills that will permanently incorporate those temporary telehealth flexibilities into state law beyond the pandemic. And these touch on a range of different telehealth policy areas, including private insurance coverage and reimbursement, Medicaid coverage, allowing for licensing across state lines, audio-only telephone consultations, and a host of other policy areas. While this is a very large number of states that have already taken permanent actions, there are some that are taking a more wait and see approach by extending telehealth flexibilities for a few years beyond the declared state of emergency, and then we'll reevaluate whether they want to keep those permanently, or by setting up working groups and committees to study telehealth best practices. So, for example, Arizona enacted legislation that did make a lot of permanent changes, including requiring private insurance reimbursement for telehealth to be the same as in-person care, referred to as payment parity. And they also allowed for interstate licensing. But they also did set up a telehealth advisory committee to develop best practices and guidelines related to telehealth, including which telehealth modalities are most effective and which populations are best served by telehealth. Vermont also created a working group called the Facilitation of Interstate Practice Using Telehealth. And it charged this working group with looking at waiving licensing requirements for out-of-state providers who want to deliver services to in-state residents. And tracking these flexibilities that are being extended or permanently incorporated into state law is very much a moving target. And with roughly half of the states still in legislative session, these numbers and relevant state examples are bound to change and may have even changed by the end of this presentation. So take this all with a grain of salt. Next slide. But with this flurry of legislative action, the regulatory landscape around telehealth is in a significantly different place. So let's take some time to look at 50 state trends for certain telehealth policy areas, starting with private insurance. So even before the COVID-19 pandemic, legislation related to private insurance coverage for telehealth had been advancing in the states. According to the Center for Connected Health Policy, 16 states had private insurance laws for telehealth back in 2012. And that number has since proliferated to 43 states and DC. Next slide. Now, these private insurance laws vary greatly in what insurers are required to cover and in some cases reimburse for telehealth. So 40 states and DC require coverage parity, which typically involves insurers having to cover a service delivered through telehealth if that service is also covered for in-person care. But beyond coverage parity, there are 20 states that require payment parity, which ensures that the reimbursement for telehealth is on the same basis or at the same rate as in-person care. And then there are some states that do have some sort of requirement for private insurance reimbursement, but it does not constitute full payment parity for all healthcare services that can be delivered through telehealth. So for example, Massachusetts enacted a bill at the beginning of this legislative session that mandated payment parity for mental health services, primary care, and chronic disease management services. Next slide. So pivoting from private insurance to Medicaid, states have a great deal of flexibility and authority over determining Medicaid reimbursement for healthcare services provided through telehealth. And some Medicaid policies are determined through state law and legislation, but a good number of policy actions happen within executive branches through Medicaid rules and regulations. And through these policy actions, states can determine whether they want to provide coverage for telehealth, what services they will cover, where in the state telehealth can be used, what Medicaid will reimburse for telehealth, and which health practitioners are authorized to deliver services to Medicaid recipients through telehealth. And similar to the boom of private insurance coverage requirements that we have seen, there has been a very large increase in Medicaid reimbursements for all different types of telehealth modalities in the last decade. So all 50 states and DC include some sort of policy that reimburses for live video consultations, but the scope of these Medicaid policies vary greatly across the states. Beyond live video, there are 18 states in DC that allow for some sort of reimbursement for store and forward technologies. And then there are 21 states that provide Medicaid reimbursement for remote patient monitoring. And then there are 10 states that stipulate Medicaid coverage and reimbursement for all three of these different telehealth modalities. Next slide. Awesome. So with the coverage side of things covered, I wanted to spend a little bit more time discussing provider licensing and how it may affect providers who are wanting to use telehealth. So telehealth providers often must be licensed in the state where the patient is receiving care, as well as within the state that the provider is located. But because licensing can often be a very burdensome process, as many of you may be aware of, many states are trying to find ways to streamline the licensing requirement and allow for interstate telehealth and telehealth across state lines. So some ways that states are doing this include joining licensure compacts for certain specific provider types, offering temporary telehealth licenses, and then establishing reciprocity agreements with states, which are often neighboring states. So first, for licensure compacts, these allow specific providers to practice in states that are participating in that licensure compact, as long as certain conditions are met, such as that provider being in good standing in their state of licensure. Currently, there are 6 active licensure compacts for different provider types, which I have listed on this slide. And then there's also a compact for advanced practice registered nurses, or APRNs, but more states have to pass legislation to join this compact before it can become active. Then beyond licensure compacts, reciprocity agreements with other often neighboring states allow practitioners to provide care to in-state residents without having to seek out additional licensing. And there are 9 states that have created telehealth specific licenses that are often temporary through medical licensing boards or osteopathic boards. And these allow out-of-state providers to offer services to in-state residents. Next slide. Then there are some states that allow for interstate telehealth for providers beyond just physicians. And so, for example, Arizona, Florida, and West Virginia, which I have represented here with some beautiful national parks that are in those states, have all recently enacted legislation to streamline cross-state licensing requirements for providers who want to use telehealth, including licensing for athletic trainers. And this legislation allows out-of-state providers to deliver services to in-state residents without first having to seek an additional license as long as certain conditions are met, such as those providers registering with the State Department of Health and agreeing that they won't set up an in-person practice within that state. And interesting fact before we move on to the next slide, River Gorge National Park is the most recent national park christened in 2020. So keep that in your back pocket when you start doing bar trivia again. So next slide. Now, as I said, many of these state actions and legislation may not directly impact athletic trainers themselves, but rather are related to other healthcare providers. But there are a few states that are considering or have enacted legislation that specifically call out athletic trainers and allowing them to have increased access to telehealth for their practice. So I've pulled together some state legislative examples here, and I thought that I would run through them quickly and thought that would be helpful for you all. So Connecticut had authorized athletic trainers to use telehealth during the COVID-19 pandemic by expanding the definition of telehealth provider to include athletic trainers. And they recently enacted legislation that extended that authorization for an additional 2 years. Then there's Illinois and Indiana, which both looked at legislation to permanently add athletic trainers to that list of authorized telehealth providers. Wisconsin created temporary licenses for out-of-state providers delivering services to in-state residents, which is limited to the COVID-19 pandemic and declared state of emergency. And that legislation specifically references athletic trainers as one of those providers who can seek out those temporary licenses. And then Wyoming passed the Athletic Trainers Licensing Act, which expands the scope of practice of athletic trainers and requires the Board of Athletic Trainers to adopt certain regulations and guidance in relation to telehealth use for athletic trainers in that state. Next slide. Now that we have zoomed in on the nitty-gritty details of telehealth regulations and legislation and how it may relate to you all as athletic trainers, I did want to take just a little bit of time to zoom out and talk more generally about engaging state legislators on key policy priorities, whether it is telehealth or some other policy area that affects you and your practice. And we like to end these sort of highly focused presentations with this sort of discussion because, and I'm stating the obvious here, health policy is incredibly complicated and state legislators are incredibly busy with multiple competing demands. So we like to just have this sort of conversation for some context. Next slide. So legislatures vary greatly across states and how they're run. And so when you see one state legislature, you have seen one state legislature. And one really great way is to get started on looking at some state legislative policy priorities is looking at the legislative process and the ins and outs of that process in your state. For example, every state legislature is made up of a varying number of legislators, and the number of constituents that are represented by that legislator also varies. So, for example, the New Hampshire House has the lowest number of constituents per legislator, with about 3,000 constituents per legislator. And that's compared to the California Senate, where there are nearly 1 million constituents per legislator. But beyond these sheer numbers, understanding the general legislative process is incredibly important. So does your state allow for ballot measures? And does every single bill that is introduced have the opportunity to have a hearing within the committee? And then what is the general process of a bill becoming law? Schoolhouse Rock definitely had it right. And it's a really great idea to get a little refresher on that process, because I know I frequently could use that refresher myself. The next thing is to look at your state legislative calendar in your state, and do not discount when states aren't convening their legislative session as opportunities to try to meet with legislators. So what is the legislative calendar in your state? When are your legislators looking at the budget, which is an extremely busy, high priority time for the states. And then legislative sessions vary in length and frequency. So for example, there are 4 states, Montana, North Dakota, Texas, and Nevada, that meet every other year rather than every year. But then there are some states that meet all year, every single year. And then there are a good number of states that meet every single year for 45 days to 90 days at the beginning of the calendar year for their legislative session. Then there is information that is specific to your legislature and legislator and who represents your district. So important questions to ask are, who is my state representative and or state senator? Where do they stand on issues that are important to me and my practice as an athletic trainer? And then who are the legislative leaders in your state? What is the party makeup? And then what is the process for providing input on committee hearings and pending legislation? And how can you find ways to track the status of a bill and where it may be at in committee? Next slide. Another key fact is that most legislators have some other source of employment. And fun fact, the most common source of employment is a small business owner. And when it comes to state legislators, they really are public servants who are working incredibly hard, and they're being pulled in so many different directions from their constituents, state demands, lobbyists, etc. And with these sort of competing demands and their work outside of their work, legislators are often generalists that then have a handful of policy priorities where they're really into the weeds of the policy area. So because of that, legislators are often asked to deal with health issues in a piecemeal and categorical fashion because they're often very overwhelmed with all of these other topics that they're asked to focus on. Next slide. And within the healthcare arena alone, the number of policy areas that they need to look at is staggering. So that includes overseeing, implementing, funding their Medicaid programs, providing regulatory oversight for different health professions like athletic trainers, and implementing federal reforms like the Affordable Care Act. And a big aspect of these discussions are also budget constraints, which often can act as a sort of barrier to bills getting across the finish line and getting enacted. And so it's really easy to become overwhelmed with all of these health policy issues alone, not to mention all the other things they need to work on, like criminal justice, education, etc. But we've created this word cloud here to show some of the intersection of health issues, and the ones that appear larger are the ones that state legislators focus on some of the most. And I also have a couple quotes from legislators that I think really capture the sort of complexity of these health policy topics and how busy they are synthesizing all of this information on all of these different topics. And so that first quote is, "My seatmate told me this was a bad bill, so I was going to vote no on it until I realized that it was my own bill." And then going through all of this information we have here is kind of like trying to drink from a fire hydrant. So again, I think that really kind of captures the frenetic environment that can often make up state legislatures. So next slide. With all of this in mind, what are then some communication tips on engaging state legislators on key policy priorities? The first thing I would say is establish key contacts within the legislature. Identify the committee of jurisdiction and the legislators who make up that committee, who often have the greatest oversight and influence concerning different health policies that may affect you all as athletic trainers. And so this could be the committee chair, members of that committee, or your direct representative themselves. So contact these key legislators, meet with them, and identify yourself as a sort of dependable first person to go to resource on all things athletic trainers. And follow up by contacting them periodically as a reminder that you are interested in being a resource for them. And so a good time for meeting with a legislator, for example, could be if there's some new health data out there that you would think would be useful for that legislator to have in relation to athletic trainers. So you can meet with them, describe what the information means and how they can use it during legislative session and when looking at certain legislative fixes. In some states as well, the best way to get in contact with your legislator is through their legislative staffer. So legislative staffers are so great. They have so much information and they oftentimes are really seeped in the details of these policy areas that are incredibly complex. And so one of the best ways sometimes to get that legislator's attention is through their staffer, especially in states that do not meet every single year or do not meet for the entire calendar year. The next thing that I would say is raise awareness for your issues through information and resources. Education is so incredibly fundamental for legislators, especially because after each election, roughly 20% of legislators are new to the legislative body. And even those seasoned policymakers often are really wanting access to the latest data and the latest information on these policy areas. So presenting yourself as someone who has something handy, who's right there to hand them information that will be useful to them and looking at policy fixes goes a really long way. And the last thing I'll say is frame your message. So how does a certain issue affect individuals, families, or businesses within that legislator's district? Specifically, what are the costs and benefits related to a specific program or bill? And related to that, what is the return on investment in implementing some sort of policy change or policy action? And then one thing that legislators love to hear is, what are other states doing on this? So is that policy successful in other states? That is one of the biggest things that we do here at NCSL is say, X number of states are doing X, Y, and Z on this topic. And they love that information, hold on to it, and really, really leverage it. So that is incredibly important when discussing some of these policy areas with legislators. Next slide. So that's all I have for you today. And thanks again for inviting me to speak on all things telehealth and legislators in general. I'm happy to answer any questions if there have been any in the chat. I haven't been tracking that. But if you want to reach out to me directly as well, here is my contact information. And then I've also provided just some general or some really great NCSL resources that we have on telehealth, both our telehealth policy webpage, a magazine article, and some databases that we have that we track state legislation on telehealth. And then I also want to plug that we are soon releasing a new policy toolkit on telehealth that touches on a lot of the same policy areas that I've talked about with you here today. And so I can pass that on to Shannon whenever that comes out to hopefully give to you all. So look out for that, hopefully here in July is what we're aiming for. So with that, I'll pass it back to you, Shannon, and can answer any questions if we got any.
Oh, thank you. Sorry, I was trying to find the mute button. Couldn't find it.
Never gets easier. Like all this time, it never gets easier.
Exactly. So thank you, Jack. At this time, we would take any questions that you may have. I'm not seeing any in that Q&A, but I do see that we have a few comments in the chat box. Tim from New Jersey said that they have a telehealth and telemedicine regulations for athletic trainers.
Nice.
And Kristen said we had a favorable response in Illinois to our bill. It was tabled due to other COVID priority bills and budgeting needs. Our fall session is typically veto only, but we expect to see movement in January 2022 if not able to get anything going in the fall. Great presentation.
Yeah. On that Illinois bill, I think that there's been, and I can track down this article, there's been a lot of recent action on telehealth there in the state, and they recently passed legislation that is still awaiting the governor's signature from the last time I checked, that really looked at that payment parity piece and that private insurance coverage requirement. And I'm pretty sure the bill, similar to that Massachusetts bill that I had referenced, mandated payment parity for mental health services. And then they're also setting up a committee that will look at telehealth payment parity for all other services. And I know of a really good article off the top of my head that I have right here in my browser history, so I can drop that in the chat. So hopefully that would be helpful.
Great, thank you, Jack. Mary Kirkland, who was in our video from NASA, she asked, what recommendations or advice do you have for expansion of telehealth services to other NASA centers across the US?
Give me a quick second.
And then she also says, do state or federal rules apply?
I think I need clarification on what NASA centers are across the US real quick. I'm sorry about that.
Well, I don't know that I could answer that, but I'm assuming, because she's stationed at Kennedy Space Center, so I'm assuming
Okay.
other NASA centers.
Oh, like literal
Houston,
NASA.
yes.
Okay, interesting.
Yeah, so she said KCS, JCS, or JSC, Ames, HQ, JPL. Those are acronyms that federal people just love.
Like I said before, I really have an eye to that state side, but I'm happy to take that question and pass it along both to Haley, who's our federal guru, as well as my other colleague, Sydney Enlin, who really does a lot of our telehealth stuff. So I can take that and try to come up with the answer for you, because I don't know that one off the top of my head.
Yeah, I think her main thing is that they're all located in different states.
Mm-hmm.
And so would they fall under federal laws or state laws, that sort of thing. So, but yeah.
Interesting. Very cool. Yeah, I can look into that and try to provide some answers to that. I'm assuming, like, on the provider regulatory side, it's going to be the state regulations that really come into play, and like what that state licensing board authorizes for telehealth and which providers can use it. So, because that regulatory licensing side, as you all are likely very much aware, really comes down to the authority of the states. So that's what my inclination is for that perspective, but I can look a little bit more into it and get back with a little bit of information.
Yeah, she did indicate that she's working on a white paper and would love to have your input.
Sweet. So, yeah.
Very good.
And I'm still finding that one. Oh, here it is. That one Illinois related resource that I think would be really helpful and is a great example of the setting up of a committee to really first look at the details and the data related to a policy before making anything permanent. So I just sent that in the chat.
Yep, I do see it.
Cool.
Very good. Well, I'm not seeing any additional questions. So, gosh, thank you so much, Jack. It's been a wealth of information. So, and we'd also like to thank our ATs who shared their videos and their stories about telehealth and how they implemented Jeff, Amanda, Scott, and Mary. Thank you for those. And we would also like to thank the Regulatory Affairs Advisory Panel who helped put this educational series together. And finally, thank you all for your participation. We greatly appreciate it today.